Hi, this is Andrea Kane, and I am here with you on HIT 352, Health Information Systems, and we are on Chapter 11. We're also on Week 11. Amazing how that works out. We're studying Health Information Exchange this week, so let's get to it. If you are looking at your syllabus, you will notice that we are still on Learning Objectives 9.2.1 through 9.2.7 and 9.3.1 through 9.3.3 and 9.4.1 through 9.4.7. Alrighty, if you are looking at your book and following along with your book while we go through this together, you should be on page 181, Chapter 11, Health Information Exchange, page 181 in your textbook. The learning objectives from the book say that they want us to understand or believe that HIE is a positive step for healthcare, and I'm not saying it's not. I'm just simply saying they want us to believe it is and prove it to us so that we can promote it. We need to be able to describe the role and functions of the Health Information Organization, also known as an HIO, in the HIE efforts, and explain the concept of interoperability. Why is it important? And look at the benefits and barriers of HIE, compare and contrast models and methods of HIE, explain the requirements of meaningful use. Now, I have said before, probably in some of your other classes, that meaningful use is essentially over, but we need to understand the history behind it because it will leave, it will have been important and it will leave an impact, a lasting impact on healthcare. So that's why we need to understand meaningful use, but we also need to understand what it has transitioned into. So, health information exchange. That is the formal agreed upon process for the seamless exchange of health information electronically between providers and others with the same level of interoperability according to nationally recognized standards. Now, they will give you this definition, but please note, HIE can also stand for an organization that does this as well. So getting back to the definition that they just gave us, this process, emphasizing seamless exchange of information, same level of interoperability according to nationally recognized standards, keeping that in mind. It has required a shift in the mindset for healthcare professionals from treating individuals within a specific practice or facility and to understanding how healthcare organizations impact the health of the entire community. We've really gone from the old country or community practice of medicine to worldwide, global medicine, especially when you're talking about communities or cities or areas. And so with that in mind, if you think about how healthcare has changed, and how technology has exploded and how information is utilized, it only makes sense that healthcare information needs to follow. We've talked in other classes about how we've moved from cost-based healthcare to value-based healthcare. And that's an evolving concept focused on better care for the individual, better health for the community, and lower cost for healthcare through improvement of services and delivery methods. So what is interoperability? It's the capability of different information systems and software applications to communicate and exchange data. Both must be an internal and external application, and this can be very difficult to achieve. I mean, you can imagine Cerner and Epic are two of the biggest players. In fact, I would say they are the biggest players in healthcare information vendors. And they don't play well in the sandbox together. Let's just say neither one of them have been all that eager to produce interoperability. And you can understand why they want their proprietary systems to be utilized. But as we move forward, that kind of competitive mentality can get in the way of patient information being available when it's needed for giving care, especially in this day and age where so many people travel. So interoperability is really not just our government in the US, but across the world, looking at ways that we can make sure that our information systems and software applications communicate and exchange data. There are 4 types of interoperability, and you need to have all 4 of these memorized, ingrained in your brain, but not just their name. What do they mean? You will find this on the bottom of page 183 in your textbook. So make sure, hint, 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 for your weekly quiz, that you are very aware of what technical, syntactic, semantic, and process, the fact that they exist, and those are the 4 types of interoperability, and then what they are. So let's start with technical. Technical is based on hardware and equipment connectivity. So when you think technical, think hardware, software, equipment, that type of connectivity. You want devices to exchange data without corrupting it or creating errors. So you're thinking, when technical, you're thinking device, or you're thinking cabling, or you're thinking that type of thing. Syntactic goes to message format standards. How is the data formatted or structured to allow that exchange? That talks about interfaces. So it's moving the data. So making sure that the data itself is in the right format, and then how it's moved between the two. Not the cables itself, because that would be technical. So syntactic, think data format. Semantic is where you're using standardized terminologies. And these get into all the different coding classifications and other types of data set type things, where you're using standardized terminology, standardized codes, standardized consistent things that have the same meaning. Semantic. So semantic, think terminologies, classification systems, where the meaning is the same. Then you get to process. Process is where you're talking about how the workflow is maintained. So that means data protection. It means the quality between the systems, user roles, and how all that works. An example here that they give in your book at the bottom of page 183 is that the patient authorization for release of information, which varies by state, healthcare organizations requesting PHI across state lines, that can be a security access standard, impede the exchange of data. So the process. Because things are different state to state. And so you need to make sure that the process doesn't get in the middle of the exchange of information. All right, moving on. Hopefully by now in your career here in the HIT program, you have heard of the ARRA. And this is not new. It shouldn't be anyway. This was, the ARRA came into being in 2007, and it was, a big part of it was about expanding the use of health information technology to improve business efficiency and effectiveness of healthcare organizations while increasing patient safety and positive health outcomes. That's what a big section of that was intended to do. And so part of that, the ARRA, remember, is the HITECH Act. And that really set aside $19 billion of money to develop health information technology, get workforce education and training created and rolled out, And then certifying EHR products, making sure that that CEHRT was done. And then also establishing standards and vocabularies so that electronic security and privacy regs really move forward. We're catching up with the technology and the times, so to speak. So make sure that you're familiar with the fact that the ARRA, with its subsection of high tech, was meant to increase the use of health information technology, the education of everyone who would be involved in using it, the certification that it met standards because they wanted to improve business efficiency and effectiveness of healthcare organizations while increasing patient safety health outcomes. You will need to know that. All right, so high tech, just talked about this, the things that it did. Please make sure that you know the 5 items here about high tech. And the goal with high tech was really the development, adoption, promotion, and use of electronic and computerized applications to create that interoperability. So this was really the start of interoperability. The first attempt, you might say, at trying to pull everyone together across the nation and say, look, we need to do this. How are we going to develop it? Where's the money going to come from? How are we going to get people to adopt it? How are we going to promote it so that patients and consumers are on board, not just healthcare providers and workers? And then how is this actually going to happen on a day-to-day basis? In your book, it has some of the healthit.gov flyers that they produce to try and educate people. If you look on pages 185 and 189 and 192, and I think there might be one more, maybe not. Nope, just those. But you can take a look at those. All right, so it added new regulations and requirements. And now we're talking about ARRA, specifically high tech. It added new regulations and requirements, toughened enforcement, and put in increasing penalties for security breaches and privacy violations. Because the more you use electronic information, the more opportunities, unfortunately, there are for security breaches and privacy violations, which we have seen. If you go back in time and look at those online, you will see that unfortunately, as we increased our interoperability and our use of electronic health information, we did have some issues. So, what is an HIO? It is a health information organization, typically a public-private partnership that oversees, governs, and facilitates the transmission of health data between different types of healthcare organizations that have various EHR systems according to nationally recognized standards. So, what they're trying to do now with terminology is they're trying to say, instead of, for instance, it used to be that you would have a health information exchange, and that was a noun, and that was essentially what has become the Health Information Organization. So, for instance, the state of Kansas had a health information exchange, an HIE, Kansas HIE. But now it's named Kansas HIO because they wanted health information exchange to really be about the process, about how it happens, about interoperability. So if you in the past heard of an organization that was a health information exchange, an HIE, it's now an HIO. That may clarify it in your mind. And then you can have local ones, you can have regional ones. Some big cities work together to try and create regional ones. And then there have been also some local ones. They bring up the Sequoia Project eHealth Exchange. And if you are looking for that in your book, it is on top of page 187. This was originally known as Health eWay, and these groups came together to improve patient care, streamline disability benefit claims, and improve public health reporting. So that was why they were there. That's why they came together. And it is still going. I'm not sure when the Sequoia project started. It doesn't tell us when, I don't think. I'm not seeing it says when. But it has been in place definitely prior to 2016. So it's what, 4, 5, 6 years old, something like that. It is a private sector organization, and it provides exchange services in all 50 states. And I don't know, your book really summarizes the Sequoia project fairly well. So I'm gonna direct you back to that on top of page 187. I don't think I have any questions on your quiz about the Sequoia project. It's nice to know, but I don't think once you get out into the real world that it's something that you would use very much. And hopefully it would not be on your certification exam because it's a bit obscure. So anyway, here's the information they want you to have about that. So why should a healthcare organization implement and use health IT and health information exchange? Well, it improves quality of care, it reduces healthcare costs, it allows you to use clinical decision support software. In this day and age, the things that we are asked to remember, whether you're in health information management or you're a nurse or a physician or a pharmacist, a physical therapist, regardless of what your role is in healthcare, there is so much information and so much to remember. And clinical decision support is very helpful for clinicians because it brings all sorts of information together and helps them make the best possible care choices, medication choices for patients. So that is why it's such a benefit. It gets you the best practices out there. It alerts you to food and drug interactions, drug and drug interactions, those types of things. It also allows increased public health monitoring and reporting. And as we've seen with COVID, they're better able to keep their arms wrapped around some numbers through this. But I think a better example than COVID, because COVID has been a challenge on many fronts in terms of public health reporting and accurate numbers because of definitions and changing definitions and changing symptoms and all of that. I think a better example would be measles. There have been some outbreaks of measles. And by utilizing Health IT, Health Information Exchange, it's easy to identify the cases that are happening across the nation and pockets where they have suddenly expanded. And they can look at that with vaccination information and see, oh, is this an issue of not getting children vaccinated, or is there something else going on? So there are many benefits to implementing and using Health IT and Health Information Exchange, and that will continue to be so. The challenge with reducing healthcare costs is that health information technology is incredibly expensive. If we haven't talked about this in any of your other classes, at some point we will definitely touch on this, but it's millions of dollars. It is no joke. It can be 50 to $100 million to implement IT systems, full IT systems, the way that they need to be and should be. So it is not cheap. In time, it can reduce healthcare costs, but the initial layout of what it costs to put in an IT system and maintain it, not cheap. There are also benefits when it comes to reporting and monitoring population health trends. Looking at where are patients being treated for diabetes and are their complication rates increasing or decreasing? Increased use of mobile technology. Don't we see that? Cell phones, tablets, laptops, telehealth, not to mention the smartwatches. So, and that is a benefit, but that's also a challenge because when you think about it, you have your information that's being downloaded by your device or uploaded by your device, depending on what you're doing, whether you're getting into a personal health record or a patient portal. And your device does not have the encryption and other security protocols that are mandated by healthcare organization devices. And healthcare practitioners prefer to use their own personal devices a lot of times rather than using the ones provided by the healthcare organization. How do you protect that? How do you make sure that there is encryption? How do you make sure there is security? It's a challenge. So even though it's a benefit to be able to have increased use of mobile technology, it also comes with a challenge. And if you're wondering where we're at in your book, we are flipping the page right now from page 187 to 188. So there's increased and improved effectiveness and efficiency of healthcare treatments and business operations, absolutely. Improved connection between evidence-based health research and actual medical practice, definitely. That's been proven time and time again. There is some basic level of interoperability between EHRs. Despite the fact that vendors have been dragged kicking and screaming to the table, yes, there is a basic level of interoperability. Having been in organizations that have moved from Cerner to Epic or from something else to Cerner and other upgrades over time, there is a basic interoperability. There is the ability to convert data, move data, and exchange it. Every system has to have that. It's just, notice the word basic there. That's what I bring your attention to, the word basic. All right, so there are benefits for patients. There is a chance for increased patient safety when systems are used appropriately and alerts are not skipped through. Patients can set up appointment and health reminders. And it does save patient time through continuum of care. I recently ran into this. Both my kids had strep probably about 6 weeks ago. I got it too from them. Thank you very much. Anyway, they have been going to school, and the school would not take them back until I had a note from the doctor stating that they were safe to come back to school, which is understandable, a bit annoying from a parental standpoint, but understandable, absolutely. I was able to go through the patient portal and email with the kid's doctor, and the doctor was able to create the letter and upload it back into the portal. And within a couple of hours, I had those letters, and I was able to print them off to paper and send them back to school with my kids. I could have emailed those, but I thought it was better for them to show up with the paper in hand in their particular cases. But of course, they were wearing masks. And they were completely recovered from their strep. But my point is that it saved me so much time. I didn't have to make any phone calls. I didn't have to wait on hold. I didn't have to, I didn't have to drive back to town to go pick up a piece of paper. That electronic health information exchange, PHR, patient portal advancement gave me the ability to do all of that, which was really appreciated. And the same thing with test results. Depending on if you use a healthcare provider that has a patient portal, you can go in and see your test results as soon as they're posted. You don't have to wait for someone to call you, and you don't have to request a copy. It's there. You can download it, you can print it off, you have a copy, or you can email it. So you have all of those things. Equity of treatment and services, well, we're still working on that. Trying to reduce health disparities. I think prior to electronic health information, it was very difficult to figure out the fact that we did have health disparities and what were they. In my medical terminology class I teach, we look at health disparities. We look at the fact that Asian Americans, they are missed an awful lot of times for type 2 diabetes. And we talk about breast cancer in another set of that. In fact, I think that's coming up. Yes, that's a health disparity that we talk about is with breast cancer with another group. And it's just those things wouldn't have been possible without health information exchange or health information and health information exchange, where you can put things together in a data warehouse and start running numbers and seeing what's going on. You can see all of these different indicators that maybe were always there, but they weren't in a usable manner. It's not like the data just jumped out and it was like, oh my, suddenly we can see there's health disparities here, or there's not health disparities there, or we're missing something here. So in theory, equity, that will come with time as we continue to pursue interoperability and the electronic information. And we definitely want improved health outcomes for all people. Emergency and urgent care personnel can quickly determine the patient's medications, allergies, significant medical history. Yes. Back in the old paper days, they didn't have access to that. And a lot of times, it was challenging for emergency room physicians at small hospitals to get their hands on paper records for patients that were brought in. Now, EMS may have access to some information about patients. The hospital, the ED definitely does, where they're not working blind anymore. They have that. If they didn't know the person in their history, they've got it now. And so a lot fewer errors, a lot fewer delays. And then more engaged patient education and patient involvement in decisions. When you have the information, it gives you the power to decide, here's what I want to do, or here's what I want to look up, or here's what I'm interested in. Here's what I want to try. It used to be with cancer patients back in the day that they would go in and they would see their doctor. They would go through all their tests and all of that, be diagnosed with cancer. They'd go to visit an oncologist. The oncologist would tell them the treatment regimen that they recommended, and then they would sign up and they would do what they needed to do and go through the treatment. In this day and age, you as a patient, if you get a cancer diagnosis, you can get a second or third opinion. You can take your films, send them off. You can take your tests and have others look at those. You can then do some research. You can, if you go to see 2 or 3 oncologists and they say, well, oncologist A says, I think you need treatment regimen, chemo regimen A. And the next one said, well, there's B, C, and D you could consider as well. You can go online and see E, F, G, H, and then have a discussion and figure out really what's going to work best for you. Maybe some additional genetic testing needs to take place so that you can pinpoint the best, most effective chemo regimen for you based on your genetic components and cells and that type of thing, the genetic markers on your cancer cells. It may very well be that. But in this day and age, you have that at your fingertips as a patient. You no longer have to trust fully in what someone else tells you. You can go out and do the research yourself. You can say, I want to try this before we try that. It makes you a more informed individual and gives you so many more options. Decreased response time for disaster response. I think that's really important too. Because information is available electronically, things can be disseminated quickly. So, for instance, if there is a COVID vaccine that is approved soon and comes out, that information will be disseminated very quickly. As to who is supposed to get the vaccine first. Is it going to be frontline healthcare workers, as the discussion has been? When will it be available to the local physicians, to primary care physicians? And how will they determine who in their practice gets it? Will it be someone with chronic diseases, maybe COPD, that's much more susceptible to COVID? Will it be, will they identify the elderly population and recommend that they get it first? So all of these things can be done. And in terms of disasters, you think about these nursing homes in California that have had to be evacuated because of the wildfires. Well, what happens to their information if it's paper? Well, you hope they took it with them, but when it's electronic, it's backed up somewhere else. It's available online. So moving nursing home patients out of an area of concern for wildfires to an area that's safe, their information follows them. So you can see there is that benefit. And so this goes on here to talk about public health surveillance. Alerts can be sent to appropriate government and health officials to speed response and mitigation efforts. So what are barriers? Ooh, number one, financial issues. Did I not call it? Yes, it's very expensive. If you go out and look at how much, go out and type into the internet, how much does it cost usually to implement a healthcare IT system? It will be very shocking. There is a lack of complete operational and interoperability standards and vocabularies, inadequate computer interfaces across all vendors and organizations. That is something we will probably never end up getting perfect, but they're working on it. They're trying. Again, you have some vendors that are dragging their feet, and I didn't mean to pick on Cerner and Epic because they're both good companies and they both have good products. I've used both. And I'm not going to say which one I think is better than the other. I'm just saying that they do. And there are many other companies that have very good products, but they're struggling in these areas. And it's a double-edged sword. They need to come together and do it. But I understand that at the same time, they want to keep their proprietary advantages so that their competitors don't acquire perhaps some of those advantages. So that one is one that will always be there for us in one variation or another. Healthcare information ownership between patients and providers. Oh, this goes back and forth and back and forth. Medical records are owned by the healthcare organization. They are a business record. That is a legal term, business record. So the record itself is owned by the provider, whether you're talking doctor's office, hospital, community health center, what have you. The record is owned by them because it's a business record. However, the information contained in the record belongs to the patient. So you can see that there's going to be some conflict here, right? Absolutely. So there's always going to be that stress and strain, tug and pull between ownership. The information is owned by the patient, but the record is owned by the provider, and the record contains the information, and you can't strip the record from the information, and you can't strip the information out of the record. So it is a joint proposition here that is governed by all sorts of state laws as well as some federal laws. Patient identification and matching capabilities and protocols along the entire continuum of care. I have lectured in other classes about where I've actually dealt with this. If you don't use biometrics, you will have patient identification issues. And even if you do use biometrics, you still may have some overly eager people who like to merge records. And when they do that, they create overlays, or they merge two patient records together. Shouldn't happen. And biometrics really sets that backwards. I mean, it really decreases that from happening. Biometrics does not have to mean your eye. It doesn't have to mean your fingerprint. It can mean the palm of your hand. The way the veins are in the palm of your hand is one way of identifying patients. Fingerprint is another. Again, retinal scan is another. So there are plenty of opportunities for identification, but when you're talking about a photo ID, it's very easy for those to be altered and for those to cause issues in terms of matching. So that is a barrier. Having worked in organizations that did not use biometrics and organizations that did use biometrics, I'm a fan of biometrics. It's not invasive, it's not painful, and it makes sure that your record is you, that nobody else ends up being on your record. And I think there should be a lot of appreciation for that. Competition and proprietary issues between healthcare organizations, not between IT vendors, but healthcare organizations. Yeah, that is another issue as well. You think about here in Iowa, there's basically two major players. You've got Mercy One and you've got Unity Point. And those two are competitors. And I'm sure that they don't want to open up their records to each other and lose some proprietary advantages. Many rural hospitals lack the financial stability and strength to provide new hardware, software, up-to-date IT personnel, and regional geographic infrastructure for reliable transmission of data. Iowa has a lot of critical access hospitals, and critical access hospitals provide great services to the communities that they're in, but they don't have a lot of money. They don't get a lot of money. They don't have a lot of money. And that's why so many of them end up joining large healthcare organizations so that they have these. Otherwise, they just can't keep up. The profit margin is no longer there. Not that it really ever was when you talk about critical access hospitals. Some rural hospitals did fairly well, but critical access hospitals, not at all. So, meaningful use. It was meant to be an incentive program for eligible professionals. That would be physicians and, physician practices of all kinds, eligible hospitals, and critical access hospitals. Participating in Medicare and Medicaid programs that adopt and successfully demonstrate meaningful use of certified CEHRT technology. And that's another one you need to know. CEHRT, what does it stand for? And the fact that it's part of meaningful use. If you're looking at your book, we are now at the bottom of page 190, moving into the top of page 191. ARRA and the subsection high-tech, they laid out the specific components for meaningful use. And those components were, it requires the use of CEHRT. You have to be able to prove that your system meets and has been vetted and approved and has that CEHRT certification. Then your system has to be used in a meaningful way, meaning you've got to do e-prescribing and CPOE. So you had to demonstrate those. Then you had to show that you could exchange health information and that it was used to improve the quality of healthcare. And then your EHR has to be used to submit clinical quality measures, or CQMs, and other specified measures that were identified by ONC and HHS. And those CQMs became eCQMs here a few years ago. They became electronic in that they were actually pulled out of the record. When they were CQMs, you could kind of fudge a bit in terms of how you entered the information. When they became eCQMs, it was either in the record or it wasn't. Just a side note there from my days in quality. So CQMs, they were looking at healthcare processes, outcomes, patient perceptions, and organizational structures and systems. And please know this, know what CQM stands for, and know that there were criterion tools that were used to measure, quantify these 4 things. You will need that for your quiz. They relate to one or more of the quality goals for healthcare. Please make sure you know these as well. They also were for population health reporting. Anytime you see population health, you can think public health. Public health is the traditional term, shall we say, but population health is the more common iteration of that. So they're the same thing, but you'll hear them used interchangeably, and they mean the same thing. So population health, they want to be able to aggregate the data, have immunization data, look at what's happening with communicable diseases, and then other healthcare events. So CQMs had to be able to be reported, and they were required to be reported, and that was a standard function in the electronic health record that you had to have for meaningful use in order to get the money. The goal is to reduce healthcare outcome disparities between genders, race, and social economic status. All very good things that you want to eliminate. So, what is a health disparity? And this is the definition they give you. Unequal differences in health access, status, or outcome based upon factors such as gender, race, social economic status, sexual identity, orientation, disability, and geography. So it's on any of those. CMS has priority to research and develop action plans that address those health disparities in several specific populations, and those are listed here. And here are the rest. So, moving on. Models of HIE architecture. And you need to know this, okay? On page 193, there are 3 models of HIE architecture. 3 models. You need to know these 3. And you need to know the fact that consolidated also means centralized and federated also means decentralized, because there is a question on your quiz about this, hint, hint, hint. So make sure you know this. So centralized model, it allows many independent HCOs to connect with HIE and aggregate data in a central repository or data warehouse that's managed by the HIE. So that's centralized. They have a master patient index or record locator service. Make sure you know what RLS stands for. So centralized means it's all this information together in a central repository or data warehouse with a master patient index or an RLS. That's what you need to know. Some advantages: consistency of the data availability, rapid response to requests. Disadvantages: you may see duplication of data, data is not completely up to date, there's cost for supporting software. Decentralized or federated, it is not a centralized database. It's not. It is more common than the consolidated or centralized. Healthcare organizations join it. They agree to security, confidentiality, transmission, access standards, and protocols. But each separate HCO is responsible for maintaining their patient's own health records. There is an RLS, and the RLS will tell you which healthcare organization has the patient information, but then you have to initiate a query. And then the healthcare organization has to receive the query, agree to the query, and provide the information. So consolidated or centralized is basically all this information is dumped together in one place, and you can go get what you need. But you got to remember that there may be stuff that's duplicated and that sort of stuff. Federated decentralized means you put in a query or request for what you're looking for, and whoever it belongs to has to respond back. Advantages: there's no data ownership because each healthcare organization maintains its own data, whereas in centralized, the HIE owns the data. Data is always current versus you don't know how often they're dumping into a centralized one. And then it has the capability to integrate with many EHR systems. But it's hard to make sure data is available depending on technical issues of a specific healthcare organization, and the data may not always be available or complete because you may find out that the patient that you're pursuing, you're going to have to request the information from multiple healthcare organizations. So that's a decentralized model, and that's a bit more challenging to use. Some benefits, but some challenges. All right, so what's a hybrid? Because that's a little bit of both. It combines the advantages, has an RLS, some data stored in a central repository, and remainder stays with the other HCOs. So in this case, in a hybrid, it chooses, okay, this information is going to be centralized, the rest is decentralized. So instead of everything being centralized or nothing being centralized, you have a little bit that is and the rest is not. And so the stuff that is, you have an RLS for, and then you also can go out to the specific healthcare organizations for what you need that's outside of that central repository. And hybrid typically have a patient portal. So advantages, oh, we just did those. Okay, so those were the three models. Okay, so the three models, we're clear on that. Consolidated or centralized, federated or decentralized, or hybrid. All right, so now we're on to methods of health information exchange. How does it happen? And here, there are three ways as well. The first is a directed exchange. It's going to push the information. So so when you think about directed, just think of it as being pushed. The next way is query-based. You go in and you, whoops, sorry here. I guess they give us more information on query or directed exchange. So it's a push. It's standards-based. Obviously, it's got to be encrypted. It's great for lab results, summary care records, referral, public health reporting, that type of stuff. All right. Oh, and then this talks about direct trust. We're now, if you're looking at your book, at the bottom of page 193 going into the top of page 194. All right, so on to the second type. The second type is query-based exchange. This is where you have to go in and find and ask. So it's opposite of the push exchange. This is a pull exchange. So if the directed is to push the information, the query-based is you pull it. You go in, you either find it and get it, or you request it, those types of things. The last one is consumer-mediated exchange. And this is where patients control the use and access of their health information. And they do it just like they would online banking. They can say, I'm going to provide this provider with my health information. I can correct my information, and all of that. So some health information exchanges are directed where they push the information. Some are query-based where you have to request it and pull it. And then there's consumer-mediated where the patient is in control. And the patients essentially manage their information. So, all right, now we've talked about health information exchanges. Patient identification is a big part of that. How do you make sure that you have the right patient? That is one of the biggest issues with health information exchanges. So the next section is on page 195, and it goes through identity matching, also known as patient matching. It's where the HIO, the Healthcare Information Organization, identifies the right person within the database to exchange information between healthcare organizations. So make sure that you know that definition. And one of the ways that people have wanted to work on identity matching is by creating a national unique patient identifier. They've already done this for providers and healthcare organizations, but they've been wanting to do it for patients as well. So far, that hasn't happened. Whether it will or it won't, I'm not sure, but that is one of the issues that is being again debated and discussed and whatnot. I think until a definitive answer comes, um, that will be debated. I do think it will come back, though. I do think it'll come back up, and eventually I would guess that it probably will go through because they'll want to make sure that they have the right patient, the right information, that there's no guesswork involved. That's just my personal off the cuff opinion, just from watching the debates. All right, so a common method for identity matching is the use of algorithms. And that is, for instance, where you're looking at data elements and you're comparing and matching and trying to figure out. So that's, for instance, it's like patient identification in the hospital. They ask to see your wristband. They ask you for 2 pieces of identification, usually your name and date of birth, to verify that you are the person that they expect you to be. Same thing here with health information. They're looking at the data elements in the system to say, oh, is this person the same person? And then intermediate, that's more advanced. And then you also have advanced algorithms as well. I don't get into a whole lot of algorithms and all of that sort of thing. It's just here for you to be aware of. Identity management, again, going back to identity management is different than identity matching. So make sure you know that identity matching is not the same as identity management. And you need to know this definition for identity management. So make sure you study that for your quiz. And then you'll go on to look at consent management as well. Consent management doesn't mean consent for treatment or consent for procedure or anything like that. What it means is whether or not there is consent for that health information to be transmitted for healthcare. And typically, this happens when you're signing your notice for privacy practices, but sometimes it's a specific paragraph on the consent to treat, the general consent to treat. Depends on different organizations how they want to do it. There are 3 components for implementing electronic consent, and you need to know these. Please know these. In order for consent for electronic HIE to be meaningful, there's a technology piece, a law and policy piece, and a patient education and engagement piece. And so let's break these down. Patient education and engagement. You have to educate patients about their consent options. Who can release their information? When does that occur? How does it occur? What happens if they say, yes, I want my information released? So you have to prove that you've educated the patient and obtained their engagement. And again, you may do that through notice of privacy practices. You may do that through verbal activities. You may have them read through something, watch a video. There's all sorts of ways you can do that. Technology is capturing and maintaining that consent decision. You got to somehow capture that information and be able to communicate it with others. And then law and policy has to do with making sure that how you're doing the patient education and engagement and technology pieces are aligned with federal, state laws, other legal policy requirements pertaining to consent, individual choice, and confidentiality. So please make sure you know those 3 components to meaningful consent for health for EHIE, electronic health information exchange, and what each one is and does. And this just goes through management of that consent. Talks about opt-in, opt-out. There's opt-in with restrictions, opt-out with restrictions, or I'm sorry, exceptions, opt-out with exceptions. Data elements. And I talked about biometrics. What biometrics are is they are a physical characteristic of the patient that systems store and use to authenticate the identity of the patient or before allowing the user access to a system. So that's what biometrics are. So what are HIE privacy concerns? Because there are always privacy concerns, right? That's what we learn. Those are at the bottom, starting on page 197, at the bottom of 197. All health information is private, but mental health diagnoses, drug, alcohol treatment, and sexually transmitted disease identification are considered particularly sensitive, super confidential. If you've ever heard of the term super confidential, that is for mental health, drug and alcohol, sexually transmitted infection or disease. Those are things that are HIV status is another one that's particularly sensitive. The healthcare organization must determine what additional privacy and security protections are in place, because some health information exchanges may not be able to adequately protect that super sensitive information or super confidential. So what are some best practices addressing the privacy issues with HIEs? First thing is always workforce education programs, making sure anyone who's involved with this understands and follows the rules and does it for the right reasons on a consistent basis. Up-to-date breach notifications. So what happens when you do have issues? How do you address them? What do you do to follow up on those? How do you handle mobile devices? You need to make sure they have effective and strong encryption protection. What do you do when you have breach sanctions that are in policy and procedure form? Do you roll those out consistently? For instance, if you have a celebrity in your healthcare organization receiving treatment, and you go in and you run an audit on who's accessed their records, and you notice that you have physicians and nurses, as well as perhaps a couple of other clinicians throughout the organization, do you sanction them all the same? Do you sanction them differently? Does it depend on what they accessed or how they accessed it? What are your policies and procedures? What do they say? If your policies and procedures say you treat physicians and all other staff the same, then if you fire those other staff, you have to remove the physician from the medical staff, and you have to follow medical staff policies, procedures, rules and regs, and bylaws, and terminate the physician from their service, from their employment. You can't pick and choose. If you've got policies and procedures, you've got to follow them, and you've got to apply them to everyone across the organization as they are written. Business associate agreements. You got to make sure that you have those in place. It never ceases to amaze me that within the last 5 years, people still had contracts with companies who used PHI and didn't have business associate agreements in place. Terrified me and horrified me, but unfortunately it's true. You've got to make sure anyone who handles PHI has a business associate agreement in place, and that those agreements are analyzed, evaluated, and updated on a regular basis, because the work that they do for your organization may change. You may add an addendum when you add an additional service from that company. Does your business associate agreement match that contract addendum? Did you add it? Did you evaluate it? What happens if that business associate has a breach? How does that affect things? How do you make sure that they followed through on what they were supposed to follow through on? And will that change their business associate agreement in the future if there was something that they didn't do that they should have done? Risk analysis. Having worked in risk management, having been a licensed risk manager in the state of Florida at one time in my life, and having worked in quality management and done risk analyses for a healthcare organization, I can tell you that is one of the most critical things to do, is to do risk analyses on a regular basis. Have a list of things that are risks for your organization and analyze them. If you come up that it's low risk in the end, that's great, but at least you've analyzed it and figured out where it falls. If it's high risk, are you analyzing it every 6 months to every year? And are you taking steps to mitigate that risk, to prevent that risk? That's all stuff you need to do, and that's even outside of health information exchange privacy, but especially with health information exchange privacy. You know, what risks do you have with exchanging information, and how are you managing that? How are you checking on that? Are you doing audits? Are you what all are you doing? Are you doing annual education? Are you checking with the health information organization that your information is going to and making sure that they're following through on what they're supposed to be doing? And then requests for restrictions on release of information by patients, making sure that's implemented, and on the notice of privacy practices. Are you sure that the notice of privacy practices that you're using is the most up-to-date version and contains all the verbiage that is mandated by the most current law that is governing HIPAA and notice of privacy practices? I don't know. How are you going to check? And then working with those who do perform release of information. What if you have places outside of HIM that are releasing patient information, PHI? Are they following the rules? How do you know? Are they using minimum necessary? Are they keeping an accounting of disclosures? Who's printing information? Are they printing it off and just handing it to a patient family member? So those are all things to keep in mind. All right, so that is the end of Chapter 11. Sorry it took me so long. Hopefully the information was helpful to you and that you will have a great week as you go through all of this and read through it. I will be back to talk to you again soon. Next week we will be on the exciting topic of standards. Oh, I know. So exciting. We'll try and make it exciting, okay? Take care. Enjoy this week of beautiful fall weather. Try and get outside, all right? Take care.